My name is Joel Parlow. I'm an anesthesiologist at Queen's in Kingston, Ontario. In fact, we have 3 anesthesiologists up on the stage, so there won't be any cheap infighting like there was in that previous episode. In fact, we're going to be a lot more serious, I think, here. Yeah. Absolutely. This is the battle of the Europeans as well. You're still European, right, Andrea?
Oh, absolutely.
Okay, so we'll try and keep it clean. I didn't do research on the 2 debaters as the previous moderator do, so I'm going to read straight off their Tinder account here. Arguing for the resolution that if a little oxygen research is good, then more must be better, is Christian Meyhoff. Christian is an anesthesiologist from Copenhagen. He conducts large clinical trials, was the leader of the proxy trial that randomized 1,400 patients to 80% versus 30% oxygen. His research group focuses on post-op cardiopulmonary complications, including side effects of oxygen therapy. Arguing against the resolution that more oxygen trials would just be a bunch of hot air is Andrea Kurz. Andrea is an anesthesiologist from Austria who has spent much of the past 20 years working at the Cleveland Clinic in the US, where she currently is the vice chair for research in the Anesthesiology Institute. Her research interests are generally looking at perioperative interventions to improve patient outcome. So with that, you see the question on the board: is there a need for further trials evaluating intraoperative supplemental oxygen during surgery? And we'll start with the for side from Christian.
Thank you very much, Joel. In fact, Andrea and I are in agreement because we are 2 Europeans with accents, so we decided to also be boring and say no jokes. So the first one of us telling a joke have actually lost. So I think I'll start by saying something for continuing trials in oxygen, because oxygen is a drug. It is in fact the most commonly used drug in hospital, and trials have been very controversial in perioperative medicine. It has been shown that 80% oxygen reduced surgical site infection, but other trials have found no difference, and sometimes even benefit with 30% oxygen. But oxygen can also be harmful. Our perioperative research group and research groups in intensive care unit have shown that oxygen may in fact increase mortality. And oxygen has many effects on the human body. It actually is a vasoconstrictive, and it reduces coronary artery blood flow. So at the moment, we have around 40 randomized trials, and 5 of them are only at overall low risk of bias. So there are so many relevant areas to study where we have not enough knowledge. We have no idea if hyperoxia affects MINS. We cannot exclude that there is a clinically relevant effect on mortality. And what about cerebral complications? What about renal failure? What about other serious adverse events? And to make it even more controversial, the CDC and the WHO have recommended all of us anesthesiologists to use 80% oxygen for intubated patients in general anesthesia. So what to do? We need major trials investigating vascular complications, investigating mortality. So we can find a safe target for oxygen use. We need more trials.
Thank you. Arguing against the resolution, Andrea, 2 minutes.
Okay, so let me start with saying that I think I spent the last 22 years looking into this oxygen question, and I actually think that's enough. I probably started when he wasn't even in med school yet, and the very first oxygen study we published almost 20 years ago, where we thought with 500 patients, which was at that point in time a huge study in anesthesia, we had answered the question that 80% oxygen increases the incidence of wound infections. And then I actually was fairly young. I thought I had solved an important problem. But then all these other people came who kind of had to repeat the study with the exact same protocol, one of whom is Christian here. And so he then, years later, published a larger study showing that there's no effect of oxygen On wound infection, I mean, I could start criticizing that study here now, but I'm a nice person, so I don't do that. So we went back and forth. Then he published that it affects mortality. Then we published that it doesn't affect mortality. You see, we are completely on the same page here. And eventually we decided to do a study in 5,000 patients where we didn't really randomize the patients, but we used an alternating study design where we used in all our colorectal ORs 2 weeks of 30% oxygen and then 2 weeks of 80%, and we did that for 39 months. And what we found is that oxygen actually did not have an effect of wound infection. That was a little bit striking my ego because I wasn't correct with the first study. But, and in the same study, we actually looked at acute kidney injury and saw that oxygen didn't, supplemental oxygen at least didn't worsen acute kidney injury, and that it also has no effect on MINS. So I think by now we really have enough studies showing that oxygen isn't beneficial, especially in regards to wound infection, which was our primary topic, but is also not causing harm. And as I don't want to do oxygen studies anymore when I retire, I think we should put that to rest now.
Thank you. So this is the bare knuckle round. Christian, do you want to respond?
Sure, it's very easy because I can just congratulate Andrea. She had done fundamentally important work in our understanding of hyperoxia within wound infection. So,
Right.
There is other issues than wound infection. I was impressed with the 5,000 Cleveland Clinic study, but in fact, overnight I added the data to the current meta-analysis, and still we cannot refute a 20% relative risk reduction in surgical site infection, even with that study. And so, even though oxygen may not have any effect on surgical site infection, there could be mortality effect. And actually also in Andrea's study, the 30-day mortality was doubled in the 80% oxygen group at a p-level of 0.08. So, shouldn't we figure out how oxygen affects our patients? We need more trials.
Okay, heating up. Andrea, respond.
I have no clue what you do at night, but for sure I don't do meta-analysis. In fact, we did a meta-analysis, a formal meta-analysis, which took a little bit longer than a night, and added our new data to the existing data. And Christian is partially right, but only partially. The overall effect was 0. So there is no effect of oxygen. But if you weigh the studies differently, then you might get different answers. And the difficulty with our large studies was that it was actually not per patient randomized, and therefore it weighs less than the large number of patients would suggest. He's correct, there was increased mortality in the 5,000 patients, but it was not significant. And it's really hard to believe if there is no AKI, if there's no MINS, if there are no cardiovascular outcomes, the patients will die from oxygen given for 2-3 hours, months and years later. So I actually think this is not a huge big deal at this point in time.
Okay, thank you. So we're going to go to the firing line round. I have 2 questions, and I'll pose them to both of you, and you can both jump in. Number 1, Joseph Priestley is generally acknowledged to have discovered oxygen in what year? The closest wins.
As a Scandinavian, I must correct you, it was a Swede that discovered oxygen.
Wrong crowd here. There was some controversy. Okay, what year? Because it's actually only the year before.
I'll hand over the microphone to Andrea.
I don't know.
Okay.
Very simple. What year?
The answer is 1774. I know what everybody in this room's thinking. If oxygen was discovered in 1774, what the hell did people breathe before that? I did some more research. It found out whiskey was discovered in 1494, so that's about 300 years of sniffing before oxygen ever came along.
Yeah.
Question number 2, how is oxygen supplied to the folks on the International Space Station?
Gosh.
Come on, you're oxygen experts.
Yeah, but not on the International Space Station. By oxygen tanks.
Well, they're up there for a year at a time, Kristen.
Yeah, you need a lot of them.
I may have an answer because both Andrea and I have read the WHO recommendation of how oxygen should be supplied, and they actually supply at a global level, and I guess space is included there. It should be produced locally, so if you have a very rural African hospital, you should produce your own oxygen there. So I guess that's the same at the space station.
That's partially true. You get a point for that. I don't know if space is considered global, but maybe so. Oxygen is actually produced by electrolysis of water into split into hydrogen. Oxygen, the hydrogen is expelled, the oxygen is retained. So the next question is, where does all the water come from for a year at a time? So I looked that up. There's a water management system for recycling all liquids on board, including exhaled humidity, sweat, and urine. So the astronauts actually, in effect, breathe and drink their own urine. True fact. This is a $250 million waste management system developed by the Americans, which makes sense considering that their president is an expert at recycling his own excrement every day.
Oh, no.
Okay. I don't get a vote, though. Okay, so final summary to Christian and Andrea, 1 minute each.
Thank you. So as you probably have heard, oxygen and hyperoxia is controversial, and it may be related to bad outcomes. But all patients that present for anesthesia will require extra oxygen. So our question is, how restrictive can we be? And in critically ill patients, hyperoxia is related to increased mortality. We need to know if this is the case for perioperative medicine. And oxygen is in fact the most easy intervention in perioperative medicine to titrate. So we need to be perfect in this matter. If hyperoxia is bad, then we have no guidelines to what target we then should titrate oxygen to. And sadly, the randomized trials conducted so far are to some extent at risk of bias, and they have provided us with one answer, that is, if hyperoxia, 80% oxygen prevents surgical site infection. So now we need large, low risk of bias trials with relevant outcomes and some clinically important targets we can use to titrate our oxygen. Let's do the trials. Thank you.
Okay, so we need lots more trials. We just need a company that makes oxygen to fund those trials. But Andrea?
Yeah, we could all pee a lot. No, I actually suggest that we go back to what we did, I think, for the past 50 years and use anywhere between 30 and 50% oxygen. And that's what's actually done now, I think, in Europe and the United States. I do think that we know now that hyperoxia does not improve wound infection risk, but that it doesn't have major harm, at least in regards to kidney function and MINS. And so I suggest that clinicians and researchers better focus on modifiable factors such as hypotension, which is associated with many, many more complications, and therefore will concentrate on POISE 3.
Okay, so this is the part where you get to decide who wins this debate. Should we be doing more oxygen trials? Who sides with Christian that we should be doing more trials? And who sides with Andrea that we've had enough and we'll spend our money on something else?
Yeah.
Wow, that's an even split down the middle, I'm sure. I'm not sure what to do with this. I'm not sure whether to shut off the oxygen entirely on Monday or crank it up, but We'll try both. Okay, thank you. Thanks, everybody.